Good evening, everybody. My name is Dr. Dennis Goodman. I'm a clinical professor at NYU and part of our NYU Prevention Center. I'm very proud to be part of the center, and we are all very proud, those of us in the center, because as you will find out very shortly, we are all very focused on prevention. And that means we don't want you to have a heart attack or a stroke or any peripheral vascular disease. And if you have been unfortunate to have that, we want to make sure that you don't have it again. And so we spend an enormous amount of time educating people. And it's been my privilege to be able to bring this series to you with the help of Anya Coate. And I always thank her because she does an amazing job. So let's go to the next slide, Anya. You don't have to see that. Next slide. So how do you ask a question? We encourage this. Anytime during the talk, you go to the QA, which I'm sure you've now become very familiar with, and you just type a question. I'm going to be taking the questions and sifting through them during the talk, and I will ask as many questions as possible. Next slide. So these are upcoming webinars, and you can see we have 3 that are coming up. The link between oncology treatments, cancer, and heart disease. I'm sure you didn't realize there is a link. There's the date, October 21st, diabetes and your heart health, Tuesday, November 16th, and tips to avoid anxiety and depression over the holidays. That's going to be in December. Next slide. So this is to let you know that we now have made sure that you have the ability to get a recording of the talk, and it will be in our lecture library. It's on YouTube, and all you've got to do is go into YouTube and type in NYU Langone. I would encourage you to please attend our series. The idea is not to give these lectures and then have people go and listen to the recording. The idea really is that you are here with us and you hear the lecture and then you go back afterwards, or you tell your friends about it. Next slide. So this is the way to keep in touch with us. And there are many ways. There's the website, there's email, there's Twitter. Next slide. But this is the address that you'd like to know about, because if you type this in, you will then find out that you can access all our lectures and a lot of information about our center, nyulangone.org/heart health lectures. Next slide. These are some of the topics. We've had over 40 lectures. We're close to 45 now. And as you can see, a lot of these, and most of them are related to prevention. I'm a big fan of the 4 legs of the stool. Talk to every patient about nutrition, exercise and flexibility, stress management, and sleep. And so you can see many of these topics are related to that. And we've been going now for almost 5 years, and it's really one of the programs at NYU where I think everybody's very proud of it. And we love the idea that we can bring you these programs free of charge and help you to prevent, as I said, heart attacks and strokes. Next slide. So I'm very, very happy to introduce my speaker today. We are very, very lucky to have Dr. Weintraub in our program. He's been around a long time. He's a veteran. He's a clinical professor in the NYU Grossman School of Medicine, and he's one of the 4 founding members of our prevention center. That's our cardiology prevention center, which was started up in 2003. He received his medical degree and completed his internal medicine residency and cardiovascular fellowship here at NYU. He's a board certified in internal medicine and cardiovascular disease. He's the clinical director of our center and serves as an associate program director of our fellowship program. We are actually one of only a handful of training programs in the nation. Dr. Weintraub serves on the executive board of the American Society of Preventive Cardiology. He's authored 2 textbook chapters and numerous articles. He's the reviewer of many of our peer-reviewed journals. He's been involved and continues to be in several clinical studies that focus on the impact of PCSK9 inhibitors and drugs that treat high cholesterol. He's been in practice in clinical cardiology for decades, and he specializes in prevention of atherosclerosis and treatment of lipid disorders, high blood pressure, and cardiovascular disease. He's been honored by the top doctors for New York metro area since 2009, as well as the super doctor since 2009. I'm very pleased to welcome my colleague and my friend, Dr. Weintraub. I am honored to be in a place where we have the ability to have access to someone with your experience, There's nobody better to talk to us about this topic. And I'm very grateful that you came to talk to my audience. I call them our audience, because these are very educated people. And by the time they get to come to this series, Howard, they've already thought about it. They've read a lot. So you're going to have to be on your toes tonight. I welcome you. It's always a pleasure to hear you talk. And thank you for coming to speak with us.
Thank you very much, Dennis. And thank you, A, for the very kind words, and B, for the opportunity to speak. So let's just share my screen. All right, so Dennis, can I get started?
Yes, please do.
Okay. So we all understand that prevention of atherosclerosis has several different facets, and this is very important to us, and Dennis is one of the prime examples. You would like to try to prevent risk factors, and those are called primordial prevention. If someone already has risk factors, you then would like to prevent the first cardiovascular event. That is referred to as primary prevention. And secondary prevention deals with people who have already had an event and are looking to not have a subsequent event. So these are the three arms. We know that cardiovascular disease is an epidemic. This is something that gets much more common as we get older. And we see that there is a small difference between men and women, predominantly early. But by the time people enter into their 60s, the numbers are very, very equal. Genetics are very important in this regard. So people might believe, all right, I'm really behind the 8 ball. My family history is terrible. There's nothing I can do. So it turns out that's not necessarily the case. You can't escape genetics, but you can more or less influence their expression. So 3 different large epidemiologic studies depicted here. And then you look on the bottom at their lifestyle risk. So when you're looking at someone's lifestyle, you can see that based upon whether they have a favorable lifestyle in blue, an intermediate lifestyle, or unfavorable in red, you can see that the likelihood of developing cardiovascular disease is something that can be modified even independent of your genetic risk. So if there is a family history, you can make a difference about doing the right thing. I like Dennis's comment about the 4 legs of the stool, and there's so much more that we can do. We should understand that atherosclerosis starts early. This is a study that was done in Cleveland, where they took poor souls that had been involved in auto accidents and whose hearts were going to be used for transplants. And they found that 1/3 of people who were under the age of 30, 60% of people between 30 and 40, 70% of people under the age of 50, and 85% of people over the age of 50 have the prevalence of coronary artery disease. So this is something that is really not a rarity. It is something that starts developing as in your 20s. What causes this are a variety of things: inactivity, smoking, obesity, etc., type 2 diabetes, genetics. There are things that you cannot alter, such as I said, genetics, ethnicity, and gender. And one of the things that certainly you have to keep in your mind is whether or not there's been a history of cardiovascular disease. Salim Yusuf studied 15,000 patients in a study called InterHeart. This was a study done worldwide in which a minority of patients were taken from North America. And they showed that amongst the 9 major risks, the one that was the most prominent was elevated lipids. Smoking was very close, and this is important. Psychosocial issues were a very close third. So don't underestimate the importance of stress. Don't underestimate the importance of having a positive outlook. And I think this is something that Dennis has done a very good job in focusing on during all of the talks that have gone on in this lecture series. So we have to talk about diet for a minute. And there was an odd occurrence that came when Ansel Keys did what's called the 7 countries study. And they looked at coronary deaths and tried to look at them based on cholesterol. And there was this oddity that even though people from Crete had similar cholesterols to other countries, they had very low levels of coronary deaths. So this was the beginning of the Mediterranean diet. Mediterranean diet has been proven in a study called PREDIMED, And when people ask me what diet should I follow, I tell them the one that has been associated with a reduction in cardiovascular risk, not just making your blood look pretty, but actually causing a reduction in stroke and MI. So this involved men and women without cardiovascular disease. And what they were put on was either a low-fat diet, the Mediterranean diet with walnuts and almonds and hazelnuts, or the Mediterranean diet with virgin olive oil. So what has happened here is the Mediterranean diet, whether supplemented with nuts or olive oil, EVOO is extra virgin olive oil, did much better than the control diet. And I really love the quote that came along from in the Nature Reviews of Immunology. The Western diet appears to be mistakenly recognized by the immune system as a threat to the organism. And quite honestly, this could be very close to the truth. So we have confused people for years. This goes back now 1984, so 36 years. And back then we said, don't eat anything with cholesterol, right? So then fast forward 30 years and we're telling people to eat butter. So it's understandable that people can be a little bit disenfranchised because they want to know when we're going to change our minds again. So there were recommendations that have been made, and these are common sense. A diet that emphasizes intake of fresh fruits, vegetables, legumes, nuts, whole grains, and fish. That's the Mediterranean diet. Replacement of saturated fat with monounsaturated. So these are good fats that won't raise cholesterol, but do raise the good cholesterol, HDL, as well as polyunsaturates. And then a diet with reduced amounts of cholesterol and sodium is a good idea. You should avoid trans fats. This has been unambiguous and no one disagrees with that. And then there's been a little bit of back and forth as to whether or not processed meats, refined carbs, and sweetened beverages should be minimized. And I think the majority of individuals who will render advice are going to tell you to keep an eye on that. So I think it's important that we go through in 60 seconds how atherosclerosis forms. So LDL, which is the bad cholesterol, low density cholesterol, gains entry inside the wall of the blood vessel, and there it is recognized as an invader. It is recognized as being foreign, and the body, not being that sophisticated, treats it like a virus or a splinter, and there are inflammatory cells. These ones are called monocytes that literally are called to the surface of the blood vessel. They roll on the surface of the blood vessel and they sneak in between these two cells. And when they get in, it's an American story. It's an eating disorder. They start to eat and they become big eaters, macrophages. Macro is big, phages eat. And when these things eat enough lipid, they get a terrible bellyache and they die. But as they're doing it, they form what's called foam cells. And that's because they're so filled with fat, they look like foam cells. So these cells that die form a common grave that's called a fatty streak. So as this is going on, there's more fat being deposited, there is more inflammation, and these are things called cytokines. And then ultimately, a plaque is formed. It gets big enough. And then as the muscle that is within the middle layer of the artery starts to be stimulated, this then starts to produce collagen. Collagen is fibrous tissue. What is the fibrous tissue cause of? And that's because of inflammation. We all know that when you get inflammation, you get scarring. So part of scarring is fibrous tissue. This plaque, so hence this scar goes on top of the plaque. This is what keeps the plaque from rupturing, kind of like a pimple. And then the plaque gets big enough that the inner core becomes so poorly perfused and not nourished that if the cells inside start to die, the plaque keeps getting bigger and bigger. And there are enzymes that are made within the blood vessel wall, one of them called matrix metalloproteinase. There's no test on this, so you don't need to remember it. And this then acts on the plaque, causing it to rupture. I've just given you atherosclerosis 101. It is the rupture of plaque that causes 75 to 80% of heart attacks and strokes. And this is the reason why we try to keep cholesterol levels low, so these plaques don't grow and they don't get more inflamed. Do we have proof? So this is an article that was written 4 years ago, which looks at individuals' LDLs and then looks at how much plaque there is on the left-hand side, and then how many vascular sites, whether it's one that's identified, none, etc. So you can see that there's almost no atherosclerosis when LDLs are below 60, and you're just starting to see some plaque. But as plaque goes up into the average level for the in the US, adults have an average cholesterol between 120 and 140. You now have very few areas where there's no plaque, and there's multiple areas where you have 2 or 3 sites. So as LDL keeps going up, more and more plaque and more arteries are diseased. There are genetic conditions, very important one called familial hypercholesterolemia. And the big important issue here is not only that cholesterol levels are high, but you're born with it. So therefore, your exposure to the elevated cholesterol can do terrible things. And what we're looking at here, FH is the familial hypercholesterolemia, accelerates the appearance of coronary heart disease by 10 to 20 years. That's in a man. And in a woman who generally develops heart disease a little bit later, it accelerates her risk of heart disease by 20 or 30 years, meaning that instead of looking for heart disease in a woman in her 60s or 70s, you start seeing it in their 40s or 30s. This is a very important entity and something that physicians should be screening for. So there have been numerous studies done, and I'll be talking about this more as we go on, but by and large, there's never been a study that hasn't shown that lower is better. TNT is a study of statins, Lipitor versus Pravachol, Torvastatin versus Pravastatin, and they looked at individuals after a cardiac event, and as they got LDL lower, they did better. Prove It, which was a study again of the same kind of patients, as LDL got down as low as 40, the risk continued to improve. So this is something that we have been looking at, and in the appropriate patient, because not everybody needs an LDL of 40, we've been promoting appropriately aggressive levels of LDL reduction. But there's a national health survey called NHANES, and when they looked at individuals with cardiovascular disease, in spite of this, and in spite of the fact that a recommendation to have your LDL be below 70, only about 20% of individuals with significant heart disease whose LDL should be below 70 are actually there. And this is from a study from Nathan Wong in 2016. I'm going to show you a study that was written 1 or 2 months ago that shows the exact same thing. So hopefully you're all going to be in the primary prevention group. And I'm just going to show you, everybody shows a slide that's too busy. This is mine. So when you look on the upper right, the important part of this slide is that there are certain people who there's no debate, they need a cholesterol-lowering medicine. One of them would be in the top in green, those individuals with LDLs above 190. And the other 2 groups are individuals with type 2 diabetes between the ages of 40 and 75. And these are individuals who should be on at least a moderate intensity statin, and many of them should be on a high intensity statin. If you don't fall into one of those groups, you then can be subject to a risk calculator. And then based upon how you come out between whether your risk over 10 years is under 5% or more than 20%, you can then use other features to determine whether or not you need a statin. And we really have been very impressed with the predictive power of something called coronary artery calcium. So this is a CT scan of the heart that has grown enormously in its strength of predictive accuracy. The Bible, so to speak, for this is a study called MESA, M-E-S-A, the multi-ethnic study of atherosclerosis. And it is through that study that we were able to ascertain how much coronary calcium should be present in, or is likely to be present in any individual. So it is age related. So if there's a 45-year-old man who has a coronary calcium score of 15, even though that score is low, the mean calcium score for that man is 0. The mean calcium score for the 75th percentile, meaning the 3/4 level, that is still 0. So even having a score of 15 at a 45-year-old age identifies significant risk. So what is it, and you can ask whether this is something that concerns you, what is it that are risk enhancers? So if somebody has a family history of men under the age of 55 or women under 65 having heart disease, then you are at risk. If your cholesterol levels are elevated above 160 milligrams per deciliter, if you have this quintet of things that are precursors to diabetes, which is an enlarged waist over 40 inches in a male and 35 inches in a woman, elevated triglycerides, elevated blood pressure, elevated blood sugar, and a low HDL. These are such strong predictors. All you need is 3 of the 5 and you win the prize. If your renal function is not normal, we measure how well kidney blood is filtered. So this is this estimated glomerular filtration rate. And if there's evidence of kidney disease, turns out the heart is also going to be at risk. What is new to this group is the chronic inflammatory disorders, such as rheumatoid arthritis, psoriasis, lupus, and even HIV/AIDS accelerates the cardiac risk. And what is also new and an interest that we have and part of an association we're going to have with the OBGYN people at NYU is that if women have menopause before 40 or have history of pregnancy-related disorders such as preeclampsia, they're at much greater risk. And then finally, individuals of South Asian ancestry. Things that occur in the lipid in the blood, a CRP, C-reactive protein, which is a marker of inflammation greater than 2 milligrams per liter. We are very interested in lipoprotein a. I'm not going to talk about it now. I have a few slides later. And then ApoB. Every lipoprotein sits on a raft. This raft is an apolipoprotein. The bad ones are all on an ApoB raft. The good ones, like HDL, are on an ApoA raft. This is not the same as Lp(a). And then one of the things that really doctors should pay a lot more attention to is the presence of peripheral vascular disease, namely, and measure an ankle brachial index. If someone has secondary prevention, there is a schema that is used, but very quickly they decide whether you have very high risk or not. What makes you very high risk after you've had a heart attack or stroke is whether you've had a recent event and whether you've had 2 or more of these things on the list: a heart attack, a stroke, or bad peripheral vascular disease. And then there are others, but I want to just mention one, if your kidney disease is significant. Number 2, if you're a jerk and still smoke, this is a very important issue. And then there are issues in diabetes. Turns out we know diabetes is bad, but there are discriminators. So if your kidney is leaking protein, and that's called albuminuria, that is a risk. If the diabetic has reduced renal function, that is a risk. And just the duration of the disease. If you've been a type 2 diabetic for more than a decade, or a type 1 for more than 20 years, which means a person who developed insulin-dependent diabetes, juvenile diabetes, at age 10, by the time they're 30, they're at risk for cardiovascular disease. And then what we call the microvascular diseases, the disease of the retina and of the nerves can also identify cardiovascular risk. I know this is busy, but just focus on the right side. I just took you through the American Heart Association definitions. 1 year later, the Europeans came out and said, that's too strict. We should, very high risk could be anybody with significant documented plaque in an artery. So look at the last sentence: multiple vessels in the coronary arteries with 2 major arteries being more than 50% blocked. To be honest, we see patients like this all the time. They may not even be a candidate for a stent because those individuals whose abstenosis is under 70 or 80% are generally left for medical therapy. The Europeans believe that these people should be treated much more aggressively, to the point that they recommend that their LDL should be under 55. So these are numbers that many of you probably haven't heard unless you've been one of our patients for a while. Individuals who are not quite as at high risk, so just called high, not very high risk, meaning someone with elevated blood pressure, someone with a history of other major risk factors, just having renal disease. We're not even talking about major cardiac disease or people with diabetes. These are individuals who right away, their LDL should be under 70. So these two groups eclipse what the Americans have considered appropriate, and these harmonize with many of our thoughts as to where LDL should be treated. So people always ask, are we going to go too low? So Jim O'Keefe from Kansas, I don't know how he got a hold of some of these people, but he managed to measure cholesterol levels in several groups, mammals, primates, but importantly, other humans that he labels human hunter-gatherers. You'll notice that their LDL cholesterol, total cholesterol rather, tends to be in the range of 100 to 130, whereas the average urbanized American has a total cholesterol just under 210, which is why the average LDL comes out to be about 130. And then why don't we just take a lesson from where we are when we're born? Because the average LDL in the infant at delivery is a level of 30. And it's at this level that you are developing hormones, you're developing the fatty covering around your nerves and in your brain. So there is no reason that many people find to have LDL be higher. And then there are two guys named Goldstein and Brown who actually discovered LDL. And when they were asked, and they have no axe to grind, this was now 1985, and they were asked, how high should your LDL be? And their opinion was a level of LDL in the plasma of 25 would be enough to nourish body cells with cholesterol. So why it is that we're comfortable with LDLs of 70, 100, 130 is something that I find difficult to understand. So there have been numerous drugs that have been developed in the last several years. PCSK9, from where I stand, is one of the miracle drugs, namely because it went from someone's idea in 2013 after doing a genetic study to being on the market in July of 2015, which is an astonishingly rapid pace. This came because they studied people with very low LDLs, 14, 15, 16, and then when they looked at their genetics, they had no measurable PCSK9. PCSK9 is a protein that is produced in the liver cells that modulates the way you metabolize LDL cholesterol and whether you clear it well from the blood. So quickly, and people always ask, have these agents been studied well? So Odyssey is a study of Praluent, which is called alirocumab. This was a study of 18,000 patients who had had an MI within 1 year, and they got LDL down in the people that remained on treatment from 103 to 53. There was, in 2 years, there was a 15% reduction in the likelihood of having a coronary heart disease death, a non-fatal MI, stroke, or unstable angina. So this is, it was highly significant, and this is a 15% reduction. The other study with a drug called Repatha, which is evolocumab, studied 27,000 patients, and they got an average of a 59% reduction in LDL cholesterol. And what they showed was just about the same thing. Over only a couple of years, there was a very significant reduction in whether or not you're going to die, have an MI, a stroke, or be hospitalized for bad angina or urgent surgery. What was interesting is that they showed something that I tell patients all the time, which is namely that when we treat somebody, we're not treating them like they're in a clinical trial. If someone comes in my office and we treat them for 2 or 3 years, which is how long this trial lasted, we don't then say, okay, fine, you're done, leave, because this is how long the trial was. And what you get a sense of here in this landmark analysis is that within the first year, as they got the drug, there was a 16% reduction in risk. But starting at year 1, going out to the end of the 3rd year, the reduction was that much more significant and was just about doubled. So there was a 25% risk reduction. And this is important because the fact that these lines or curves continue to diverge tells you that if you were fortunate enough and you stayed on this therapy longer term, you could expect to do even better. So everybody I see, or many people I see, are worried that these drugs are going to make them goofy. So there was a trial that the FDA mandated called Ebbinghaus, in which they gave these individuals who got evolocumab Repatha, the medication, and they studied them intensively, doing neurologic and psychologic studies. And they found no differences between the drug and placebo on multiple cognitive tests, the patient's own reported cognition, and then physicians' impression by whether they thought there was cognitive dysfunction. And this is in spite of getting LDLs down to under 25. So the field of PCSK9 is evolving. There is a new drug called inclisiran. This is a drug that lowers PCSK9, but in a different mechanism than Repatha or Praluent. And this is a drug that is going to be used probably twice a year. So this is one of the early studies looking at single doses of the drug over a year versus 2 doses given at day 1 and day 90. And you can see that at the higher levels of medication, 300 milligrams in 2 doses, there was significant reduction. They then figured out that the best way to use this drug was to give the drug at time 0 and then give a second shot at 90 days, and then probably do it again after another 6 months. So the way that individuals would be dosed would be time 0, 3 months, and then every 6 months. And when you do that, you get literally the same LDL reduction that you would have achieved with either Praluent or Repatha. There is a outcome study, and all the trials with inclisiran are in the Orion family. And this trial is not going to be available to us for almost another 3 years. They expect this trial to close in 2024. So we're not going to really know whether you're going to achieve the same benefits that you got with Praluent and Repatha until this is out. But the fact that the drug lowers LDL very nicely, and that there has been a good safety signal in the individuals who have been treated is very promising. And the word is that this drug will be available for use in the first quarter of 2022. Another drug that has recently come out is called bempedoic acid. This trade name is Nexletol. This is a drug, the family of studies is in the CLEAR family. And by and large, it showed that the drug lowered LDL cholesterol 15 to 18%. There was a very interesting finding that when they gave it to people who are on a statin, they got another 15% reduction in LDL. But in individuals who were not on a statin, namely people who might be statin intolerant, they did considerably better, making this drug a very interesting choice in individuals who might be unable to tolerate a statin. And then the other thing was that there is no involvement in the muscle. So the incidence of muscle aches, which really occurs in about 7 or 8% of patients, almost did not occur with this drug. And they came out with a fixed dose combination of bempedoic acid with ezetimibe that used to be called Zetia. And here, the fixed dose combination, FDC, was a 36% reduction. And the same reduction was achieved in inflammatory markers. So this now becomes a very promising drug to use, particularly in those that have not been able to be on a statin, but still may have significant benefit in those who are on statins. And we're going to know more about this drug as well, because their outcome study called Clear Outcome will tell us whether this drug, when given to people on a statin, I'm sorry, not on a statin, pardon me, is going to be able to reduce cardiovascular disease. Finally, for those people that are really having trouble in spite of getting a PCSK9, there's a new medicine called evinacumab. It costs a fortune to use, but in individuals on statins, on a PCSK9, they're able to get significant reductions in LDL cholesterol. This is a medicine that needs to be given by intravenous infusion, but there'll be more studies on this, and there'll be a different version of it. So Lp(a), why should we worry about it? So Lp(a) is an LDL molecule, this little yellow thing in the middle, and you notice the ApoB on top of it, but this LDL has a tail. So this tail have these things called kringles, and this is what tends to create the atherosclerotic risk. So unlike LDL, which would be proatherogenic, meaning forming plaque, and may cause some degree of inflammation, this also causes clotting. So this is like the holy trinity. You have the possibility of accelerated plaque formation. You have increased inflammatory response, which mediates more plaque formation. And then if this plaque becomes at all unstable, the thrombotic potentials make this that much more concerning. And what we know about it is that with a normal value of 29, if your number is 117, so that would be about 4 times the upper limits of normal, just look at where this circle is, your cardiac risk is tripled. So this is something that I think we have to take very seriously. Individuals with Lp(a)s of 3 to 4 times have about a doubling of risk. So this is the reason why we've been involved with this, and while there are now significant trials. So one of the reasons why we also like PCSK9s is they lower Lp(a) better than anything else that we have available to us now. So in the trial that I told you about called Fourier, they looked at people with Lp(a)s that were elevated. So Lp(a)s starting above the median below the median versus above the median. And those individuals who had high Lp(a)s got even more benefit. So the reduction in events was significantly better. And if you look at this graph here, it's kind of simple. If this is now on treatment, if you lower your Lp(a) below the median, and that your risk would be significantly reduced, versus if your Lp(a) was high and your LDL was high, this comes down about 30%. So this is a very impressive therapy. It is one of the things that we look to try to use PCSK9 inhibitors in, but what's around the corner are 2 different medications. One of them is called pelacarsen. This is what's called an antisense oligonucleotide, a big word. What it essentially does is reduce the formation of Lp(a). So this was the phase 2 trial that we were involved in. And what they more or less showed is that giving between 60 and 80 milligrams a month lowered Lp(a) by 70 to 80%. And the side effect profile was pristine. We are now involved in a trial called Horizon, which is recruiting patients with elevated levels of Lp(a) and a history of stroke or heart attack. Because of our work in this, we have been named one of the 4 national lead centers for this trial. The other drug that is also accelerating through these trials is something called olpasiran. So if you remember inclisiran, this is a drug that's kind of in the same family as inclisiran, but instead of lowering LDL, it specifically lowers Lp(a). So this was the phase 1 study that you'll notice we were involved in. And they got reductions in Lp(a) that after one injection lasted 9 months in some cases, particularly with the higher dose, and got Lp(a) down in the range of 80 to 90%. So there are two very good drugs that are sort of in the stables being nurtured. My hope would be that at least one of them would be out in the next 4 to 5 years, but obviously I can only say film at 11. One of the things we have learned from an article from the group at Wake Forest is that there is an additive effect on Lp(a) when inflammation is present. So as Lp(a) goes up, when CRP is elevated, the impact on cardiac events is even higher. So this is going to motivate us to probably keep an eye on this marker even closer. So finally, the question comes, what do we do about triglycerides? And there's more and more interest in this. You can see that triglycerides have a major involvement in cardiovascular events. One of the major ways to treat them is omega-3 fatty acids, predominantly marine sources. And the two biggies are EPA and DHA, right here, DHA and EPA. The REDUCE-IT trial is something that has gained remarkable press. 8,100 patients with elevated triglycerides and coronary disease on a statin, and both the total number of events and first events were reduced phenomenally, 30%. For those of you not familiar with statistics, this says, what is the likelihood that this is a fluke? So the fact, a p-value of 0.05 or 0.01 is significant. This p-value says that there is no way this is a fluke, and became a very impressive trial. But the problem, this trial was done with a drug called icosapent ethyl that is only EPA. There was another drug that was developed that's a combination of EPA and DHA, and the study was called Strength, and here there was no difference. So there's a lot of controversy going on, and all I can tell you is keep tuned, film at 11. The one thing I can tell you is those of you who are taking dietary fish oil or supplements, unless you have a very high quality fish oil supplement, you're essentially wasting your money. Because when they looked at the content of these fish oils, only about 21% of any one pill was EPA, 9% was DHA, a third was saturated fat, and another third was other fats. So you're taking a fish oil and potentially getting bad stuff inside your system. I think we got to be careful about that. And this is what they look like. Which one would you rather take? So this is the prescription omega-3, and this is the dietary supplement. I leave the choice to you. So in closing, we've got to get over this. A patient of mine sent me this, and I can't tell you how realistic it is when the patient asks, how long do I have to ignore your advice? Everybody quotes the idea about statins being bad. A study that was just published last month looked at individuals who were given atorvastatin for 4 months, a placebo for 4 months, and then nothing for 4 months. So even when they were given nothing, some of them had muscle pain. When they were given the placebo and when they were given the statin, they by and large had the exact same amount of muscle pain. So they developed what they called a nocebo ratio, which is symptoms on a statin divided by symptoms on placebo. So I think it's something that we need to take seriously. So you'll know that if you see one of our people in our center, we're going to look at the potential of statin intolerance seriously and make sure that it's being done right. There was a study called the Gould Registry published in June, which looked regrettably at what I call therapeutic inertia, which more or less means that if you start out with LDL cholesterol levels over 100 with coronary artery disease or stroke, the likelihood is over the course of 2 years, you're going nowhere. The only time that people did better, I'm sorry, this is in blue, the only time that people did better and got LDLs down were when they were on a PCSK9. And we all know that LDL should be below 70, preferably below 55. And a lot of these patients, it is the people on PCSK9 therapies, either alone in people who are statin intolerant, or those who are on a triple header, a PCSK9, a statin, and a ezetimibe. So the likelihood of getting an LDL cholesterol to 55 or lower approaches 50%. Whereas in other individuals using statins or a statin with ezetimibe, the likelihood is not nearly as high. And we try very hard to make sure that individuals who we think need the statin, the PCSK9, get it, because if the patient is rejected, which can happen in about 61% of the cases, there can be a 16% increase in the risk of heart attacks or strokes. And then there are other people, regrettably, and this is very unfortunate for me in my mind, that who are approved, but they can't fill the prescription because the copay is too high. They face a similar risk. So do we have absolute proof that lower is better? This is a little complicated slide, but I'll take it, and we only have about another minute left. This is looking at the Fourier study, the one I mentioned to you about with Repatha. And they looked at whether getting LDL below 40 was going to reduce risk. So these are individuals who started out with LDLs that were like in the 70s or 80s, and about 38% of them got their LDLs down below 40 milligrams per deciliter. And the same curve that you see here shows the risk of cardiovascular events. And don't you know that as LDL went down, so did the risk of a cardiovascular event. And I think that this slide will be the one that I'm going to close with, because this is an article that we wrote that was presented at the American College of Cardiology in May. And this looked at 33 trials with 250,000 patients followed up for 50 months, so more than 4 years, looking at individuals on statins, et cetera. And what we showed was that the lower the LDL was, and the longer you got cholesterol lowering therapy, the better you reduced vascular events. So individuals who are on very intensive LDL reduction and who had been on it, for years, they had the very best reduction in cardiovascular events, whereas those individuals on low doses of medicine or not taking medicine for a long time did not do as well. So as they say, the medicine doesn't work unless you swallow it. So at this point, I'm going to leave you with I think is a very important slide, and that is namely that superior doctors prevent the disease, mediocre doctors treat the disease before it's evident, and inferior doctors treat the full-blown disease. I thank you very much for your attention. I look forward to your questions.
Okay. I hope everybody can see me and hear me. Dr. Weintraub, that was outstanding. To me, that was lipids 101 up to 1001. So there was really a fortune of information there. And anybody who is interested in what's coming down the pike, you just got an introduction to the latest stuff that we are currently researching. And as Dr. Weintraub told you, we are very involved in our center in the latest medications. And if any of you have any interest of coming and being in one of our studies, you just have to contact us, and you can go through the website I gave you. And we can put you into one of these studies, specifically a study that lowers LPA. We're trying very hard to prove that if you lower LPA, you're going to reduce cardiovascular events. Now we're going to spend another 15, 20 minutes. And I have so many questions, Howard, so I've got one favor to ask you. I don't know if you can do this like a sound bite.
Sure.
Maybe I've got 10 or 15 questions, and I want to try to give the people who ask a question an answer, a bottom line answer. So I've got a whole number of excellent questions. And the first one, we've written some of them down if they were sent to us previously. And here's the first one. At what age should someone consider medical therapy if they have borderline cholesterol? And let's say if they have high cholesterol or borderline cholesterol, and at what age, and here's the question, would you be putting someone on a statin if they're at very high risk?
In a male, I'd be happy to put them on a statin in their 20s, only if they fail lifestyle modification. I think they must learn to exercise and eat well. In a woman, I might be a little bit more reluctant simply because there can be some issues with statins if a woman gets pregnant. So at that point, I may hold it off.
Howard, would you say that people or children with familial hyperlipidemia need to be treated in their teens? Would you just comment on that?
By all means, the statins are approved for treatment in people, down into the early teens, and they just approved Repatha for use in children as well. This is brand new. So yes, by all means, Dennis, someone with familial hypercholesterolemia, I would not have any reluctance to start medications in their adolescence.
Thank you. And in that regard, we're talking about children who have a family history where there's been a parent, a brother and sister who've had heart attacks at a young age, 30s, 40s, and 50s. So please, if you know anybody like that, please have the family checked. Come and see a physician and make sure that they get lipids performed. Correct, Howard? I'm sure you agree with that. We've got to be aggressive about finding those patients. So who should and shouldn't use Repatha? I think you covered this. Maybe you can just summarize it. When do we go onto Repatha and when do you not need it? And it's got to do with the LDL levels, but if you could just put that into
It's a matter of globally of risk. So it is the LDL in the light of their cardiac situation. If their LDL is very high in the absence of cardiac disease, or their LDL is even moderately elevated while they're on statins and ezetimibe, or if they're statin intolerant, I have no reluctance to use this drug. Dennis pointed out that I've been doing this for decades. There are very few drugs that I can't think of a drug that I haven't had to stop in at least somebody. Repatha is a drug, as well Praluent, that I've not had to stop in anybody because the side effect profile is literally benign. So I feel comfortable doing it. And the results have been, as I'm sure you found, Dennis, great. And some people get great drops in their Lp(a).
Absolutely. I just want to add something to summarize. The fact is that if a person needs to bring their LDL down, and this is particularly people who've had a prior heart attack or stroke, we call that secondary prevention, they should not be happy unless their LDL is very low. And it's so important to understand that if their LDL is not really low, we have a new drug, we have another drug. So discuss that with your physician. You should not be happy with an LDL of 90 if you've had a heart attack or a stroke. So that's very, very important. And if you reach out to your physician, you will find out they know about it, and they may even refer you to our center to see someone like Dr. Weintraub. Another really good question. When should I check? I'm going to say, when should I check my lipids for the first time? Mm-hmm. And how long after starting a statin would you recheck it? And I'm adding one other thing. Do we have to worry about liver function tests anymore? Everyone was so concerned about their liver, and now that's gone out of the window. So could you comment on those three things?
Sure. So again, in the average individual, I think they should be checked early, in late adolescence, in their 20s, because we see so many people that have never been checked, and they first find out their cholesterol's high when they're in the cardiac cath lab getting a stent. How long after you start the statin? Generally, I use with say, atorvastatin and rosuvastatin, that's Crestor, you get 80% at 2 weeks and 100% at 4 weeks. So I generally would wait 6 to 8 weeks. It tells me what the drug's going to do. And it also gives a chance for the patient to show me they're tolerating the drug. And I would then draw the blood test at that point. So far as liver function tests, they used to tell us to measure liver function tests frequently. They want you to measure it once after. So when you draw the blood for the cholesterol, check liver function tests. And after that, you're under no obligation to check liver function unless you have another clinical reason to do it.
Or would you check it if they say the drug is increased, say like going from lipid 10 to 80? I think you can make a case that in your high dose of a statin, you check it one more time.
You know, Dennis, I'm a big fan of using a little lower dose and adding ezetimibe, simply because of you can forego some of the side effects that are a little bit more likely at 80 than they are at 40 of atorvastatin or at 40 versus 20 of rosuvastatin. So I find you get very good mileage out of those doses, and really the difference in effectiveness is marginal.
I think that's such an important point, that people who land up having some side effects from a statin, if you lower the dose and you add ezetimibe, or your doctor wants to increase your statin to a high dose, maybe you don't need a high dose because we can add ezetimibe. Always something to discuss with your physician. The medication is called Zetia, and it's very helpful to lower LDL, and often it means that you don't have to increase the dose of a statin. What are the long-term side effects of statins? I think what the question here is, is there any downside for long-term statin use? You did allude to the Ebbinghaus study, but can we say, conclusively, statins don't cause any long-term side effects? And by that we talk probably cognition. People worry about, we discussed the liver already, and other people worry about their muscles. And of course, we should mention rhabdo, but there aren't major long-term side effects that'll stop us using these statins because of their significant benefits. What would you say, Howard?
I absolutely agree, Dennis. You're right on that. The drugs have been available now for over 35 years. They came out in the mid-'80s, and there's been no skeletons in the closet. And I think all the reviews have shown that, whatever side effects there are, they're very rare, and that the benefits significantly outweigh any of the risk.
Okay, I think this is a good question for me. I'm going to come back to it because I want to make sure we get as much time with Dr. Weintraub as possible. And these questions are related to supplements, and I will take them just before we finish. Let's take this one. I love this question. We've heard about the sticky, tiny lipids, small, dense LDL. You mentioned Lp(a). What does small, dense LDL mean? What does it mean that these sticky, tiny lipids, are they any stickier than the sticky ones?
So, Dennis, I like the words are entertaining. They don't, it's not that they stick. It's just that when someone has a high triglyceride, the LDL particle becomes enriched with triglyceride, which makes it a smaller, denser molecule, hence small, dense LDL. And there are a lot of people with high triglycerides. They're not really sticky. It's just that they don't get cleared from the blood as well. So they don't really, so I guess, and as a consequence, if they stick around, it's like any other garbage that is not picked up from the street. It stays in the street longer, or in this case, your blood vessel longer, and ultimately gets taken up into the artery. So it's just a matter that these are not cleared. They're allowed to circulate around. And if they circulate around enough, they get oxidized. And when they're oxidized, they become more likely to form plaque.
Excellent. What do you do now? We got two questions here, and I really enjoy both of them. What do you do if your good and bad cholesterol are both very low, but your triglycerides are very high?
Okay.
And let's take that one first, because this particular person who asked this may not realize that low HDL is not so good either. But I think we should tackle the question of your cholesterol is looking pretty good, the HDL is looking pretty good, but your triglycerides are very high.
So triglycerides on their own are really, the jury's kind of out as to whether in that circumstance you're likely to get atherosclerosis. What we worry about, because you said very high, is that if the triglycerides are very high, meaning over 500, then that puts you at a risk for something you don't want to have, which is pancreatitis. Pancreatitis can present with nausea, vomiting, and abdominal pain. And if it's bad enough, it can end you up in an ICU with a tube in your stomach. So this is what we worry about more. If there are reports in most individuals who are going to have high triglycerides will also have some elevation in their cholesterol levels as well. And that's where the triglycerides turbocharge the cholesterol. And it's like adding 1 and 1 and getting 3. So the second bullet is the one that we worry about more as the risk for cardiovascular disease. And there's a relatively linear increase as triglycerides go up above 150 and more than 200, 300. And then as the triglycerides get over 400, 500, once again, the risk becomes less cardiac and more pancreatitis.
Excellent. I think in summary on that question is, if your triglycerides are high, especially if your HDL is low, because they often go together, they're a team, please get a physician to look at that, and Dr. Weintraub will be happy to see you or anybody from our team, because high triglycerides is important. And the most important thing, and I'm sure Dr. Weintraub will agree, most high triglycerides are because someone is overweight.
Exactly.
And we can lower triglycerides very well if people get onto a good nutrition program.
I just want to, Dennis, one thing, triglycerides, the patient can out-eat whatever we give them.
Yeah,
So
I remember you taught me that 10 years ago. You said any patient can out-eat a statin. In other words, don't think because you're on a statin that you're now okay, because you can out-eat it. And it's the same with triglycerides. I have to give a shout out to somebody the name of Stephen Ho, who sent me about 10 questions. Let's see if we can take a few of them with one-word answers. And then I have 2 or 3 quick ones. So let's see if we can go for another 5 minutes. Okay. Which of the statins have the least side effects? Is one better than another?
So there are 2 statins that have less drug-drug interactions. That's pravastatin and a drug called pitavastatin, which is Livalo. Livalo is really even more unique in that regard. The truth of the matter is, we've seen people not do well on pravastatin. They do fine on atorvastatin or rosuvastatin. Insofar as what's the best statin for me is the one that works the best.
Right.
But but you got to keep trying. And if somebody has a lot of statin side effects, sometimes what you got to do is even though you might not get a lot, you'll get something. So pravastatin used with ezetimibe, you can get some pretty good LDL reduction, and at least the patient's on medicine and not feeling unwell.
So it's important to realize you could be on a statin with side effects. Why not try another one? You may try something at a lower dose. I think something you taught me, Howard, is you can take a statin maybe once or twice a week, and you'd be amazed at and I think we should just comment on that, because you can get rid of the side effects and maybe you don't get 100% of what that statin's capable, but 50% could be good enough.
You have a great memory, Dennis. It's good that I forgot it. The drugs that specifically work best there is rosuvastatin and atorvastatin, because those drugs last a pretty long time. So we've seen people take the drug twice or 3 times a week, and they get pretty good cholesterol reductions. And amazingly, they tolerate the drug very well. And there are a lot of patients there. Every once in a while, I look at my charts, and there are a lot of patients that I'm doing that in. It's called giving in to get your own way, making sure that you get on medicine. And if you just need to think beyond the box.
You know what, Howard? I've had many patients over the years where they're on like a Crestor or a Lipitor once a week. Or twice a week. I've been amazed that they can bring their LDL cholesterol into a range that we're happy with. So I know that it's not in the package insert, but we've got to remember that that's better than not taking it at all.
Exactly.
Stephen asked about CoQ10, and I'm going to answer it quickly. CoQ10 as a treatment for side effects for statins. I think Howard alluded, Dr. Weintraub, to the fact that there's no good scientific evidence. And there are some controversial studies, but I am going to say, and Howard, you can pick on me if you want. I've had patients, I put them on CoQ10, 200 milligrams a day, and they tell me that their muscle aches have gone away, or they no longer bothering them. And we don't know if it's a placebo side effect or what. But we do know that statins reduce CoQ10, which is basically something involved with energy production. It's also an antioxidant. So I am prepared to say the jury's not out yet. And if we can get somebody to feel better, sometimes it doesn't matter how it's happening. And I'm sure you'll agree with that, Howard.
I agree 100%. And there are patients that I have who have taken CoQ10 and do great. Let me just add that many people do better on ubiquinol, which is the alcohol form, rather than ubiquinone. So that if you're looking for better bioavailability, take the 200. And if the 200 is working and you need a little more, don't hesitate to go to 400 milligrams a day. And I agree with Dennis. There's no good published data, but when you've been around as long as I have, and Dennis is, has certainly been working as a cardiologist almost as long, you see a lot of patients and you'd be surprised how often CoQ10 will help. And there's no downside. So giving it is always worth a try. I don't start it immediately when they're on a statin, and I don't start it before they get muscle aches. Do you start them before they get muscle aches?
You know what? It depends on the patient, Howard. I have many patients that are very open-minded about trying being on a supplement that may help you. And if they ask me, I go, yeah, I've got no problem with it because it lowers. But for most patients, I say, let's see what happens. I definitely put them on CoQ10 when they get muscle aches, but as you know, many patients, most of them don't. Maybe it's 10 to 15% of patients who have a muscle ache. So if a patient's got an open mind to it, I tell them there's no harm, try it. And the trouble is you don't really know then whether it was helping you or not helping you, but the bottom line is they like taking it, and I've got no problem them taking it if it's going to help with reducing side effects. And there are other benefits as well. Okay, quick one. What about carotid IMT scan versus a calcium scan? Are you concerned about the radiation? I'll just quickly tell people the radiation from a calcium scan, we're not talking about CT angiogram, is about 1 millisievert, which is about 10 chest x-rays, or similar to a little more than a mammogram. So Howard, I'm going to have you weigh in, and then I'll tell you what I think about this.
So in an individual, the algorithms for coronary calcium start at about age 45. So in an individual over the age of 45, I think the data is much stronger for prediction of cardiovascular events with a coronary calcium score. In someone who's younger, say someone with familial hypercholesterolemia, or someone who is worried and they're in their 30s, doing a carotid IMT is something that works. But I caution you, you need to go to a center that knows what they're doing. They need to have a very good technician who knows how to do the carotid scan, and there needs to be a reader. So this is two elements of the test that need to be put together, which is the reason why it's not as popular as CT, because all they do is lie them down in the gantry, they press a button, and in 5 seconds, the scan is done. So that's one of the things. So I think CT has been my go-to, but I use carotid IMT on occasions.
Right. Howard, I think we're going to agree on this, that the benefit of having that information from a calcium scan is so huge. We spend so much money on tests looking for risk factors, but if you can get a definitive test that tells you whether you've got heart plaque or not, I think it's worth a small amount of radiation. And I think we're both saying the same thing.
I agree.
The only time I scratch my head is when someone's got a history of a cancer, a breast cancer, for example. I don't want to order a calcium scan and then be told, I was fine before you ordered that. I think we have to scratch our heads there, and I think you must make a decision in conjunction with their oncologist. I'm sure you'll agree with that too.
I agree with that too.
I got two great questions. I want to ask you them because the one is so related to what we're doing now in our center. My 34-year-old daughter was just diagnosed with severe psoriatic arthritis, and to our surprise, she has high cholesterol. She eats healthy. Is there a correlation between her diagnosis and heart disease? Well, I think we're gonna be coming out with a very strong recommendation soon that patients with connective tissue disorders should see a cardiologist. Would you want to comment on that? And
exactly right. As a matter of fact, we are one of the few centers in the country, in the world, and certainly in the country, that has a center that does cardio-rheumatology. Michael Garshik is the young man who has really spearheaded this, but I think this is a very important situation. And even though the young lady is 34, her cholesterol's high, she has a lot of ongoing inflammation. And I think that this is somebody who I would be very attentive to her cholesterol risk factors. And this is someone who I would, without hesitation, give a statin to.
Okay. This is from Kavita. She says, I'm not sure if it's her or she's talking about in general, there are a lot of patients 40 plus years old, in other words, in their 40s, they got LDLs over 190, their ASCVD risk, in other words, their risk score is below 7.5%. Should we start a statin right away, or should we do a calcium scan first? Excellent question. And just before I throw the question to you, Howard, I think we got to make it very clear. we talk about statins all the time, but they're not a panacea.
Right.
It means that you're using them in conjunction with lifestyle changes. It's extremely important. So what would you say about that patient who's 40-something, very high LDL? Do you go straight to a statin or would you get a calcium scale?
So officially, the LDL over 190 is you are told to adopt what I call the Southern Trooper mentality, which is shoot and ask questions later. I think that there are individuals that I've seen with LDLs over 190 that have clean coronary calcium scores and clean carotid studies. And these are individuals that if they're young, we have an open mind and I say, what can you try to do to get your cardiovascular risk down? But the majority of these people ultimately are going to need a statin, is what I find. But there are people I've seen in their 50s who have had LDLs in the range of 190, very good HDLs, which may be very important. They may have pot scrubber HDLs, and they have no evidence of atherosclerosis. One of my mentors is a guy named Bob Vogel, who is in Maryland. His mother died at 90 with an LDL of 290s, with a total cholesterol of 296. And Bob was a very aggressive guy. And when we talked about it, he said, you know what? For her, the right cholesterol was 296. So that harmonizes with what you're talking about. And she lived just fine without anybody giving her a statin.
I think the bottom line is that when your cholesterol's high and you don't think you need a statin, you must be absolutely sure that you've got a calcium score of 0.
Exactly right.
And that's what it is. Don't just ignore the idea because you don't want a statin. I'm going to answer 2 more quick questions. One is, Howard, can I get an LPA and routine blood work? Should I ask my doctor for it?
Yes. Our view is this is a genetically mediated lipoprotein. All you got to do is measure it once. If it's normal, you never need to check it again. But if it's 20% of the world has a high LP(a), and so it's one blood, all the doctor has to do is add it to the blood test.
Yeah, 100%. It's very easy to order it. I think if you mention it to your doctor, firstly, any lipidologist or cardiologist is going to order it, but anybody can order this test. It's very, very helpful. And if it's high, as you've heard today, you're at increased risk. You should definitely see someone about reducing risk factors. Of course, your primary care physician can do that. When your LPA is high, your risk is higher.
Sure.
Right. 2 quick ones. One is, again, my friend Stephen Ho. How come it's okay to have olive oil and nuts and all these things that are in high fat? They're telling us this is good for us. Don't they cause hyperlipidemia?
So these are monounsaturates. These are good fats.
Yeah.
So olive oil is one of the things that promotes monounsaturates, which means it'll raise HDL. But you got to be careful because it's 125 calories a tablespoon. So if you start drinking it, you're going to get pretty fat. But there are good things about it. It improves vascular function. It's not going to raise your bad LDL. So that's why we do it. And nuts have the same kind of omegas, most of them, particularly the tree nuts, like walnuts, almonds, hazelnuts. These are the same omega-3s or similar omega-3s to what you get in fish. The ones in fish may be a little better, but if you're vegan and you don't want to eat fish or you're allergic to fish, nuts are a very good source. What do you think, Dennis?
I agree with you. We call them good fats. It's going to be good for your brain. The more you can get stuff naturally, the better. I mean, I call that God's garden, and there's everything inside of that that's going to help you. It's really important that you don't take olive oil because we think it's good for you, that you take a cup of olive oil for your salad, because it really will cause weight gain. And so everything in moderation. And a quick one, another one from Stephen. If I've got a stent, what are the things that to prevent reocclusion? Well, listen, when we talk about reocclusion, there are 2 things. One's restenosis, the other's a total blockage. From a blood clot, aspirin's crucial. Some of the platelet inhibitors like ticagrelor and Plavix are crucial. You asked if vitamin K2 will prevent that. Absolutely not right now. We don't have the data. I'm going to end with a 1-word answer because many of you asked me about supplements like bergamot, and CoQ10 and vitamin K2. I think I'll do a series. I'm going to do a lecture on it. It is something I have expertise on. None of these things are to replace a statin when you need it. Bergamot can be very helpful. It comes from a citrus tree from a place called from Cambria in Italy. And there have been some studies that show it lowers LDL and cholesterol. Howard, I'm going to surprise you. I took it myself. My cholesterol and LDL came down 60 points. We need it in our toolbox, because sometimes people are either having side effects of statins, or we want to add something that will reduce LDL even further. So have an open mind on it. And I'm looking forward to the day, maybe in a few years' time, you go, you know what, Dennis, you taught me something in exchange for all the tons of things that you taught me. Dennis, I'm going to give you the last word, but I want to say what a pleasure it was to have you. I've got tons of questions. Maybe we should have Q&A on lipids instead of you giving a talk first. This is such a sophisticated audience. There's so much information. We encourage you to be in touch with us. We have a prevention program where you can see people like myself or Dr. Weintraub and get a ton of information and not have to be, in the dark about whether you should be treated and how you should be treated. And what you'll see is exactly what you saw with Dr. Weintraub today. We don't just go, well, we think maybe we should. We go according to evidence-based medicine. And that's changing at times, but we do know, and we're very on top of what that is right now. Howard, last word to you.
Dennis, you put it very well. I think everybody should be aware that there are opportunities for integrative medicine. Dennis is one of the world experts, and I think we utilize his knowledge and talents, and I think it's something that there's a place for in many patients. But as Dennis said, what we know now is the data that we have that shows about reduction, either preventing atherosclerosis, maybe even making plaque a little bit better, but certainly in those people at the highest risk who've had an MI or a stroke or have familial hypercholesterolemia, getting LDL down in a definitive manner, in a purposeful manner, is something that's very important. You got to keep your eyes on the goal. You can't just give the drug and walk away. You got to figure out what is your target. And if you haven't reached it, find out why. Is the patient not eating well? Are they not exercising? Or do they need another drug? And I think
are they out eating the statin, Howard, which is probably
exactly right.
likely to.
That's exactly right.
I just want to thank everybody for staying with us. I can see there are a whole lot of questions. We'll have to get to them another time. I also want to end by saying a huge thank you to Anya Coates, who makes this series happen for me. We do a lot of work, and I'm very blessed and lucky to have people like Dr. Weintraub. Nobody says no to me when I ask them to come onto this series. If there's anything that you'd like me to address, please let me know. We're only too happy to try to educate you in things that you'd like to hear about. So I'm going to sign off. Howard, it's been a pleasure.